Good afternoon and welcome everyone. This is the second ever ACTnet Tough TB meeting, and thanks to everyone who's taken the time to drop in this afternoon. And my name's Alice. I'm a respiratory physician at the Royal Adelaide, and my co-host is Vicky Gray, who you see there, coming to us from Brisbane, and she's an ID physician at Logan Hospital, and we both also work as TB physicians at our respective services. So in the next hour or so, we're going to be presenting 5 clinical cases in quick succession, and along the way, we'll pause and direct some tricky questions to some expert panellists and hopefully have some good discussion. Please also make sure you type your own questions in the chat box, and hopefully we'll have time to come back to some of those at the end or as we go along. So I'd like to welcome our guest panellists, who are Dr. James Geake and Dr. Matt Roberts. James is a respiratory physician. He's sitting here with me at the Royal Adelaide and also at SATB Services, and Matt's an ID physician also at the Royal Adelaide and is our local transplant ID guru. And so thanks both so much for your time and your expertise, Matt and James.
Thanks, Alice.
Thanks for having me.
Before we start off, in the spirit of reconciliation, we'd like to acknowledge the Yagara, Turrbal and Kaurna people this afternoon, who are the traditional custodians of the country from which we're presenting today. We respect their connections to land, sea and community, and we pay our respects to their elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today.
Thank you, Alice. Thank you. So we have 5 cases lined up for you today. The first 2 will focus on the use of TB preventative treatment for potential organ donors, as well as for recipients whose donors have had suspected prior TB exposure. We then also have cases that will cover the challenges of paradoxical upgrading reactions and concurrent fungal infections, before ending with a life-threatening hemoptysis TB case. So, kicking off with our first case, we have a 40-year-old man who was born in the Philippines, and he's being worked up to donate a kidney to his son. He moved to Australia 20 years ago, and as part of his transplant workup, he's had an IGRA, which has returned a positive result. He has no symptoms of active tuberculosis. So I have 2 questions, and I'm going to direct these first at Matt. My first question is, if you were seeing this person in clinic, what other investigations would you order, and what would be your approach to management?
Yeah, so I suppose the main thing I want to do is exclude active TB. So there's no history that's suggestive of that. I'd do an exam to make sure there's not any signs of that, lymphadenopathy, those sorts of things. I'd probably also ask him about whether he had any immigration screening and what the result of that was. It'd be interesting to know. But then in terms of investigations, he'd, as a minimum, need a chest X-ray. And as part of his workup, at least at my centre, he'd get abdominal imaging of his kidneys. So that would exclude having a tuberculoma or something in his kidneys. And then I'd also look for sterile pyuria and probably do some urinary AFBs, although the yield of those is pretty low and probably not that likely that he has urinary TB, but that would be prudent to do. If that all turns out that he doesn't have active TB, do you want to keep going, or any questions about that?
Yeah, no, I was going to say that's similar. That's exactly what we did. We, did the baseline chest X-ray and then urine MCS looking for sterile pyuria, and then went on to do urine AFBs as well. So after you're happy that you've excluded active TB, what would you do next?
Well, I would try and treat this person before they donated their kidney. This person's only 40 and is donating to their son. Presumably their son is 20 or so. So you don't want to keep people waiting a really long time at that age group to have a transplant. So I'd be planning to try and treat them in advance of donating and looking to give one of the shorter regimes, so maybe like weekly dosing with dots with rifapentine. Then that's only 3 months that the transplant would be delayed. And I think the ideal scenario is to try and treat the donor before transplant. That avoids the need to necessarily treat the recipient after transplant when they're often having other problems and you've kind of limited to only giving isoniazid to that group. So my preference would be to try and treat the donor. Of course, that's a discussion with the transplant team as well. You need to have an understanding of how urgent the transplant is. And if this is a young person who's trying to have a preemptive transplant, you might not actually have 3 months to wait. So it may be that you just have to transplant and then treat the recipient for latent TB.
So is it, say, if it wasn't urgent, would it be a barrier at your centre if, say, he really didn't want to take preventative treatment? Would that be a barrier to him going on and donating his kidney at your centre?
Well, that would be something that would be a little bit concerning. I don't know that it would be a definite barrier. There's a few things to consider. One is the recipient. You've got to think how likely it is they're going to be able to take latent TB therapy. Is there anything else going on? If you did that, there would be a risk that there could be TB transmitted with transplant, which could be terrible after transplant, albeit that risk is probably not that high in a kidney transplant, but still possible. I'd be really surprised if a father wouldn't take some medication to facilitate their son's transplant, but maybe they have an allergic reaction, or they can't tolerate it, or they get bad hepatitis or something, and you have to stop. In which case, you just have to work through that and perhaps try and give the recipient treatment if you can't give it to the donor.
Yeah, there was only one patient at our unit recently who wasn't very keen to proceed, and that was because she thought it would slow the process down. And ultimately, yeah, she was able to go on and donate her kidney. But yeah, we would just notify the transplant unit in that setting if someone didn't want to proceed. I just wanted to show this very useful resource, which basically discusses risk stratification for TB infection in potential living kidney donors. It goes through all the screening that's recommended and subsequent management, so worth having a read through at a later point for anyone online if you're interested. But we'll move on to the second case. So this is also.
Can I ask a quick question before you do that,
yes.
Vicky? Just
yeah.
I was just interested to ask Matt and perhaps yourself as well. I mean, I guess noting that preventative regimens aren't infallible, it's come a long time ago. So, but I guess infection with drug-resistant organisms possible. Is there any specific different post-transplant surveillance that is done in this setting? I mean, I guess they're surveyed pretty carefully anyway after a transplant, but do you do anything differently, I suppose, in the recipient in this setting?
I don't think that they would get any additional monitoring in the recipient if their donor has received adequate preventative treatment. Matt, what were your thoughts on that?
Yeah, I probably wouldn't monitor the recipient any differently if the donor was treated. Most cases of donor-derived TB, it's very hard to determine if it is truly donor-derived TB, but in the literature, most cases are usually in the allograft if it recurs, so that's a little hard to monitor for other than clinically. Like, I don't know that there'd be a role of doing serial urine AFBs or serial imaging. I think that would probably be pretty low yield. I wouldn't necessarily do that.
Thanks, James. Thanks, Matt. Okay, so the second case. This case concerns a 40-year-old female who's now day 3 post her liver transplant for her primary biliary cirrhosis. She had no personal risk factors for TB identified prior to transplantation. Her donor had recently moved to Australia from India and then died suddenly from a subarachnoid hemorrhage. You receive a call from the transplant coordinator informing you that the donor's IGRA has returned an indeterminate result. So I have 2 questions, and I think I'll direct these at Matt again. What other information would you ask at this point? And then what would be your clinical approach to recipient management?
I suppose this is interesting. I mean, deceased donors routinely per TSA and Z Transplant Society guidelines don't get an IGRA. So I'd probably ask why it was done. And my concern would be about, was anyone looking for active TB and had decided to send an IGRA? And most of my questions would be about if there is any evidence of active TB in the first instance, because the risk of transmission with someone who's active TB would be much higher than latent TB. And then I'd be trying to work out, I'd want to know a bit more about the IGRA. Is it indeterminate because of an inadequate mitogen response, or is it indeterminate because of the TB antigen responses? Presumably this person who died, I'd want to know some clinical information, but presumably they're in ICU and critically unwell. And so it's not unusual for people to have inadequate lymphocyte responses, and potentially that might explain why there's an indeterminate response. The next bit of information I want to know is about the epidemiologic risk of this person, and we've got there that they're from India. I want to know if there's any known TB contacts, whether there was any immigration screening. You're probably not going to get that information. Whether there was any known past history of TB, any of those sorts of things. They would have been imaged as part of their workup for donation, and I want to know the results of that imaging. And then I'd want to know if any other organs were transplanted, in particular the lungs, because as a part of a lung transplant, all donors will get a BAL, in particular for AFB. Hopefully that was negative. Hopefully the culture is still negative as well. But that would be, I'd be trying to stratify, is the indeterminate result real? Does it represent active or latent TB infection?
So you're basically told that the IGRA was ordered because she was born in a high incidence TB country, and the decision was made to order it at that time. She has had some washing sent, smear negative, culture negative to date, but obviously still early. No known TB risk factors and no concerns for active TB before she died, but that's sort of the extent of the information you get told. So I guess in terms of the second question is sort of focused around, do you think that the recipient needs to be given TB preventative treatment? And if so, what would you choose and when would you look at starting it?
Yeah, I just thought of some other questions that I'd ask you, Vicky. I would also ask the surgeon, who I have ready access to, was there anything macroscopically in the kidney? And I'd also find out, they often take an implantation biopsy. Was there anything on that that looked like granulomatous inflammation? I presume the answers are both going to be no, but they would also be things.
Okay, no, that's interesting to know about though. But yeah, so assume that it was all, the surgeon has no concerns.
Yeah. So then, I mean, I suppose as someone who's got an epidemiologic risk for TB who's a donor, I would probably think they could have latent TB, and I'm reassured that all that testing suggests there's not active TB. There is a risk of transmission with latent TB that's very poorly quantified, and I see someone's put that in the chat. What is the risk? It's not well known. Because there's not good data from Australia and there's not really good data from the US. So I would be looking to try and treat the recipient for latent TB. You've mentioned there that the recipient has no risk factors for TB and presumably had negative TB testing prior to.
Yes, she did, yeah.
So I'd try and treat them for latent TB. They're very likely as a liver transplant recipient to be on tacrolimus, which is going to make it impossible to give them rifampicin or any sort of rifapentine, anything like that. So you'd be limited to mostly isoniazid-based regimes. That is a challenge because, of course, after transplant, the LFTs will be deranged for a period of time, and any derangement in LFT prompts a whole series of concerns about whether there could be graft rejection, and that has a whole bunch of repercussions. So isoniazid would be the first drug that I would consider using. I'd probably wait for the immediate post-surgical period to die down and have some improvement in the LFTs with some graft function before instituting that. So I'd try and do it within the first few weeks. Most of the cases of donor-derived TB occur within the first 3 to 6 months of transplant, but not immediately. So you've got a little bit of a window to wait while those things resolve. And yeah, I'd be looking to do isoniazid.
So that's what was attempted, but the issue was, so she was offered isoniazid during her index admission within sort of first few weeks. The decision was made to try and offer it earlier rather than waiting. But she, as you said, not uncommonly had issues with deranged LFTs, and that was an ongoing issue for multiple different reasons. And ultimately, she decided she didn't want to take another medication that might cause further issues. So when we caught up with her at clinic, we re-offered it a few months down the track, but she still wasn't keen. And so we've just decided to keep her under clinical surveillance, which we're planning to do for a minimum of 2 years.
Could I, just before we move on, could I just draw you out a bit on the tacrolimus rifamycin interaction? Is that not something that can be overcome by, escalating tacrolimus dose and with level monitoring? Is it too hard to achieve therapeutic levels, or is there a second issue?
I think it would be very hard to get therapeutic levels. And the problem is that you risk having subtherapeutic levels and then precipitating rejection, which could be a really big problem. So I suppose if you'd think about it more seriously if you were treating TB and you really need to have rifampicin. But if you're just treating latent TB, I think it's probably pretty hard to justify putting people in that scenario. That's my feeling.
Yeah, thank you.
And I guess the other option, other than isoniazid, would also be using a fluoroquinolone like levofloxacin or moxifloxacin. Do you have much experience with using those instead? Do you have a preference for Moxie or Levo in that setting? Or do you sort of
I don't have much experience doing that, but I know there are reports of centres that do that in liver transplant, and I don't think they necessarily know how long to give, and I'm not sure there's a lot of data about how well it works, but some places do it.
I mean, I've used levofloxacin for preventative treatment, I guess, outside the transplant setting for a few patients, and sort of I've been more confident using those since the TB Champ and Vequin RCTs that were looking at levofloxacin in MDR TB contacts, with the results supporting their use. But I haven't used it in the transplant setting. But yes, I think it would be a good alternative. Okay, we're going to move on to our third case, and Matt, we might give you a bit of a break and direct these next questions at James. So our next case is a 20-year-old male with cervical lymph node TB. This was detected by a gene expert. Rifampicin resistance was not detected, but we were never able to get a positive culture, so further drug susceptibility testing was never possible. He completed 6 months of treatment with first-line therapy. He was on DOT the whole time, no compliance concerns. And then 3 months post-treatment, he developed contralateral lymph node swelling. So what would be your approach to this, James?
So I mean, it's not a super uncommon scenario, I guess. I think at the end of the day, this is most likely to be a post-treatment paradoxical reaction. When lymph nodes come up after treatment, it's much more common than, for example, disease relapse. It's come up within a time window that is typical for post-treatment paradoxical reactions, particularly in lymph nodes. So I think it is probably a paradoxical reaction. However, I guess when this sort of thing happens, there are other possible etiologies that you need to consider, and as I mentioned, most importantly is their disease relapse. It had a expert confirmed diagnosis. We don't have the phenotypic sensitivities. Presumably hasn't had a XDR cartridge done, so. I guess there's a possibility of isoniazid monoresistance. I guess a very, very low chance of rifampicin resistance, despite the experts. So, but assuming that's not the case, I guess there would be a slightly higher chance of disease relapse if they had isoniazid monoresistance. So disease relapse, I guess, possible. Like the other consideration, and where certainly I've been burnt once or twice, is maybe this is something completely not TB related as well, and remembering that TB can coexist with other conditions, particularly conditions that might be immunosuppressive, so lymphoma, for example. So I guess I think that's the least likely of the three options, but that alternative or concurrent diagnoses I think would need to be considered. So it's 3 months. I suppose the other thing, it's in a different lymph node, which is a bit less typical for post-treatment paradoxical reactions, but still I guess well recognised in nearby regional lymph nodes. I would, I guess the first thing to know is is it uncomfortable in any way? Is it upsetting for the patient? But so that might, to some extent, direct your subsequent therapy. But certainly at this point, I'd ask for a repeat, ultrasound guided core biopsy of the lymph node.
Yeah.
And I'd ask.
Sorry, I interrupted.
Yeah, no. So on that, I would obviously send it for mycobacterial cultures, histology, and probably flow cytometry as well. I guess just considering that less likely possibilities.
Oh yeah, so yeah, it wasn't bothering him that much at this stage. We did exactly what you said. We organised a repeat biopsy, sent for histocytology and culture. The histology showed necrotizing granulomas, but TB again not cultured. We'd repeated his chest X-ray. There was no other sort of new findings on that, and he remained clinically well. So I have two sort of follow-on questions from this. Would you request a gene expert on the second biopsy? It's my first question. And presumably, if you presume this is a paradoxical upgrading reaction, as my next question, what would be your next steps in management?
So I probably would request a gene expert, but not from a diagnostic perspective. I would anticipate really that there'd be the high likelihood that the gene expert will be, detect MTB. It would be reassuring. I guess he's had DOT therapy. There's been no questions around adherence, no questions of absorption. So generation of resistance with the regimen he's had would be, extremely unlikely. But I guess it'd be reassuring just to confirm that there's no emergent RIF-resistant mutations. And I guess if you could, ask the lab to do an expert XDR cartridge, that might also help with that sort of nagging question of whether there had been isoniazid monoresistance in the first place. So I think it might be helpful just as much from a reassurance perspective as anything else. And so I probably would do it in that context, yeah. And then what would I do next? I guess the initial steps are either, careful monitoring and watching if it's not causing too many problems from a functional or cosmetic perspective for the person. I remember my old boss, Rick Stapleton, when I first went into, asked him about a patient like this, and he came in with a syringe and a needle and stuck it straight in and aspirated some pus. So, that's, I haven't done that in a while, but that's, that is an option, I think. I guess if it's getting bigger, if it's a functional problem from the patient's perspective, then and if the cultures are all negative, you could consider a course of prednisolone to see if that helps settle it down.
Okay, great. So so as I said, we assumed it was a paradoxical upgrading reaction. It kept getting bigger, so we sort of we decided to start him on prednisolone. We gave him 30 milligrams daily, and he had a really good initial response. We did a fairly rapid taper. But then he developed recurrent lymph node swelling again, this time back at the original site of infection, with a lot of purulent discharge. And at this point, he's getting sort of quite unhappy, and it's sort of finds this reoccurrence more disfiguring because of the associated discharge with it. Prednisolone was restarted. There's some response, but every time you drop the dose below 20 milligrams, the lymph node increases in size again. So where would you go from here?
Yeah, I mean, so this is a tricky situation, isn't it? Obviously, a young person, you don't really want them on doses of prednisolone like that for a long period of time. It's funny, we had a TSANZ meeting, a local one, 2 or 3 weeks ago, and one of the guest judges was an endocrinologist, and they were aghast at how much prednisolone we use in respiratory medicine. So I guess with that lesson in mind, you would be looking hard to see if you can get them down off prednisolone. We have had one case in the last 5 years of a CNS paradoxical reaction where TNF-alpha inhibitor therapy was used, and I'm aware that my colleague here, Alice, has been involved in a recent, what's very similar to this actually, using infliximab. I think.
It was infliximab.
So, I mean, I guess they're used, they're not completely benign medications, but they're used lots, obviously, in rheumatology and inflammatory bowel disease, etc. So, and probably in terms of risk benefit with the higher doses of prednisolone that is being required at the moment, I think it would be a reasonable point now to explore TNF-alpha inhibitor treatment.
That's what we did. We involved our local immunology service to consider what potential steroid-sparing agents might be an option. The decision was made to try Humira subcutaneously fortnightly for a 6-month course, to which he had an excellent response to, and has had no recurrence after ceasing. There was a discussion about whether to use infliximab, as you've mentioned, instead. Our immunologists thought that given that it was nodal disease with a paradoxical reaction rather than CNS, Humira would have been fine. They thought that if it had been CNS disease, that they would have preferred infliximab, but Humira was the more practical option for the patient, so that's why we went for that. Excellent response. I think, Alice, your case you had less success with more recently.
Yeah, well, I mean, it's arguably still early, but I had a very similar patient, but there was microbiological confirmation of the diagnosis with positive TB culture initially. And for that person, has had a really difficult time with persistent fistula and discharge, and that's cosmetically been a concern for her, and also not able to tolerate prednisolone. But I got approval for 3 doses of infliximab just following review of the literature. That seems to be the schedule 0, 6, and 12 weeks, I think. And we're at about 10 weeks post the 3rd dose, and there's been perhaps a marginal improvement, but the fistula has settled down. So it's not been kind of the amazing result that you described, Vicky, but I guess I'm keen to see what happens in the next few months.
Yeah. And this just, I won't dwell on this slide, but if anyone wants to come back and refer to this under the recording, obviously feel free, but just a quick summary of some of the case reports and theories that have been published. Essentially, there doesn't seem to be that much evidence for TNF blockers for paradoxical reactions in nodal disease. The reports are mostly in CNS disease, and infliximab is usually the reported drug of choice.
There's just a interesting question from the chat box. Any thoughts about excision or surgical management as an alternative? Was that pursued? I can talk about that in my case, but what did you do in yours?
So we didn't consider that because of concerns of poor associated wound healing and creating issues with fistulas if it was excised. So that's why we went down the route of pursuing sort of a TNF blocker instead. I think generally surgery is avoided in this setting because of issues with poor wound healing following. Is my sort of understanding of it.
Yeah, I had a similar experience. My patient's been seen by plastics a couple of times, and they had concerns about just basically saying would be impossible to excise due to the bulky and very sort of matted fibrinous nature of what was there, and also concerns about very likely a poor cosmetic outcome, keloid in that region and whatnot as well. I found reviewing the literature, I found one very pro excision of lymph node early paper from a high TB incidence country, but that's really a standalone narrative. I haven't found that backed up anywhere else, so I don't know if that's just a single unit that's gone rogue somewhere.
Okay, I think we'll move on to the fourth case, because I know our fifth case is a little bit longer. So the fourth case is a 30-year-old man with smear-positive cavitary pulmonary TB. He has no significant past medical history previously, HIV negative. He's undergone a bronchoscopy as part of his diagnostic workup. TB's been detected by a gene expert on washings. He's been commenced on HREZ. And then you receive a call from the lab. He's about a week into treatment at this point, and you're told that Cryptococcus species is now growing from his washings. So Matt, I'm going to come back to you for this one. Obviously, James, feel free to contribute as well if you want to, though. But Matt, what would be your next steps after getting this call from the lab?
I'd want to see if the lab can tell me anything else. Can they tell me what sort of Cryptococcus it is? But that may take a little bit of time before they can do that. I mean, the immediate things that I could do that I should get a result for pretty quickly is a serum cryptococcal antigen. And I'd also make an assessment of whether he's got any neurological symptoms that would make me concerned about CNS cryptococcus. And then I'd go on to do some imaging of his CNS and probably a lumbar puncture to exclude CNS cryptococcus.
Okay.
Yeah.
So what we did, we whilst we were waiting for the species, we got a serum cryptococcal antigen that was non-reactive, a CT head which was normal. The species was confirmed as being Cryptococcus neoformans. Unfortunately, it failed to grow on the Sensi titer trays to allow for appropriate reading of susceptibilities. But you've answered my first question, which was going to be to ask you whether you would do a lumbar puncture in this case with someone with a non-reactive serum cryptococcal antigen who's otherwise immunocompetent, but obviously who has the Cryptococcus neoformans from growing in their lungs. And then my second question is, do you always need to treat this?
Yeah, so I suppose maybe just to articulate why I wanted the species is there's an environmental cryptococci. This is a Crypt neoformans we know can cause invasive infections. It's unusual to do it in an immunocompetent person, but it could happen. And it is probably unlikely that he has CNS cryptococcus with a negative serum cryptococcal antigen. But if he does, then the treatment is very different. And there are some data that if you have a very low crypt antigen, there's still a risk of having asymptomatic meningitis. So, I mean, I would do a lumbar puncture. I think it's an invasive but relatively low risk procedure, and it would significantly change my management if it was positive. So I do that. And then do you need to treat it? Well, I think it's probably hard to say that it is an environmental contaminant because this person has pulmonary changes on their CT chest. So probably most of them are driven by TB, but to say that they're only TB when you're growing Cryptococcus is probably pretty hard to do. I would probably treat it.
Yes, so what we made that same conclusion. It was going to be impossible to rule out pulmonary cryptococcosis given the extent of the disease that he had on his CT chest. So we decided to to treat. Before I tell you what we did, what antifungal therapy would you choose, and what I guess dosing considerations might you consider with his TB therapy, in particular his rifampicin?
Yeah, so I suppose the options are either getting combination Amazone and flucytosine or fluconazole alone. And I think it's, if I thought that he had severe pulmonary cryptococcus, then I would be thinking about Amazone and flucytosine. I think that's maybe a little bit of a stretch to say that, because probably most of his lung changes are likely to be driven by TB, given you've only grown it on a culture, his serum cryptococcal antigen is negative, there's no evidence anywhere else is immunocompetent. So I think I'd probably discount the Amazone flucytosine, given all the side effects and the need for inpatient admission, and go with fluconazole. And I'd be concerned about the fluconazole rifampicin interaction. You mentioned that you didn't have sensitivity, so that would be a little concern for me, because occasionally there are higher MICs of cryptococcus to fluconazole, and you sometimes have to give quite high dosing. The risk is probably going to reduce the fluke, and so I mean, I'd probably be trying to get like 800 upfront to try and overcome that.
Yeah.
So you have to think about, is there a role for levels? I don't know if you thought about that. I don't know that there's good literature to support doing levels of what you target, but that'd be something I'd think about.
Yeah, so what we decided to do was to give a standard 800 milligram loading dose, but then give higher than standard dosing. We involved our ID pharmacist and arrived at 600 milligrams daily for 6 months. So I guess the rationale, as you've alluded to, is that you get decrease. Well, there's been sort of an observed somewhere between 20 to 50% decrease in fluconazole AUC when given rifampicin. So I think it's important to consider fluconazole dose increases. We discussed the role of TDM, and ultimately we decided against it in this case, as the rifampicin had already been commenced, so we weren't going to be able to get pre and post rifampicin levels to see how much the fluconazole level decreased. So we thought that potentially there could have been a role for fluconazole TDM if we had started it first, but probably wasn't going to be that helpful with the rifampicin already on board. I think just another important point is that, for those in the audience who don't know this, that the interaction between fluconazole and rifampicin likely begins about 1 to 2 weeks after co-administration and continues for about 2 weeks after stopping rifampicin. So if rifampicin for any reason was to be stopped first, you would want to continue the higher fluconazole dose for another couple of weeks before returning to standard dosing. But yeah, that's ultimately what we decided to do, and he had a very good clinical response and radiology improved. And I think almost certainly what was driving the radiological change was the TB, but we just didn't feel comfortable ignoring the cryptococcus.
Yeah, so, I agree. I mean, the risk crypt can progress, and then they'd get disseminated crypt. That could be bad. So, yeah.
Okay, so that concludes the 4th case. So we're going to move on to the 5th case, and Alice is going to take over presenting. So over to you, Alice.
Thanks, Vicky. So our 5th and final case is a little bit longer, but I think maybe worth the story. So this patient was a 28-year-old Australian-born male who was referred to our ED following an episode of hemoptysis in the community and CT findings that were really concerning for TB disease. In terms of past history, he had a history of alcohol dependence and was often in and out of sobering up units. And also notably, he'd been identified as a TB contact 3 years prior to this presentation and was offered TB preventive treatment and did receive 6 months of isoniazid monotherapy at that time, with good documented adherence because he was incarcerated at that point. So when chatting to him, he reported being really quite unwell for several months. He'd lost probably about 15% of his body weight, and he had a full hand of respiratory and systemic symptoms, essentially, but also very concerningly, he reported these 2 episodes of large volume hemoptysis in them 4 weeks or so prior to presentation. So we made a plan to keep him safe and have a good emergency plan ready to go in the event of further hemoptysis. Admitted him, obviously, and then commenced standard 4 drug therapy, given the very high index of suspicion. And there was, in fact, microbiological confirmation of that diagnosis within 24 hours on a sputum sample, which was heavily smear positive as expected. Interestingly, he did go on to have further imaging of his abdomen and brain. That was unremarkable. So this did seem to be just a very high burden of disease that was confined to the chest. So I'll just show you some axials here. You can see in the right upper lobe is a very thick walled cavity, and there were actually smaller cavities together with nodular infiltrates and areas of more constant consolidation in all lobes, and some bulky mediastinal nodes. So this is a graph representing time in weeks from admission, 0 being point of admission. So in the first few days, he did pretty well. As we often see with some TB treatment on board, he just felt much better constitutionally. So stronger fevers did settle pretty quickly, and his appetite came back. But unfortunately, on day 6, he had a code blue for very impressive hemoptysis. And I guess at this point, I just wanted to emphasize that this is not sort of streaky hemoptysis, which he was having all the time mixed in with purulent sputum, but this was really, really frightening frank blood sitting up with it just coming out, about 300 mils all up collected in the bag at that first code. And at that point, he was obviously rushed down to CT. There was no active blush on angiogram, but he was monitored for a time in ICU. And then after a few days with no recurrent incident, he was discharged back to the ward and continued on treatment. So unfortunately, he had a couple more of these really alarming episodes, and there was some further discussion with our interventional radiology colleagues who agreed that that thick-walled cavity at the right pole was by far the most likely source, and they did think that the site was amenable to bronchial artery embolization. So this is the IR view pre-embolization on the left and post on the right, and the IR team were pretty happy with the result. At the time of embolization, they did note quite significant arterial pulmonary venous shunting, and they flagged that at that point that even though technically they could do more proximal embolizations, because of those anastomoses, there'd be a pretty high risk of systemic embolization. So it's a pretty difficult situation to be in as a young man, and there's a risk of stroke with this potentially life-saving intervention. So next slide, if we can, Vicky. Unfortunately, despite that really good radiological response, embolization doesn't really appear to do anything clinically, and he goes on to have 2 further episodes of awful hemoptysis in the days following the procedure, and he's understandably terrified. So at this point, we're approaching week 3 of treatment with 4 drugs, and at this point, phenotypic susceptibility is confirmed to rifampicin and ethambutol, but there's a tiny bit of growth on the isoniazid plate, and that's been set up a second time to reassess. So in the interim, particularly given he's got this history of the isoniazid exposure, we modified treatment to account for the possibility of some isoniazid monoresistance, and we also sent off some drug levels, and then obviously acknowledging the imperfect nature of the test, we ran an MTB XDR cartridge, and that was negative. So we had some limited reassurance there in terms of this being hopefully still susceptible disease. So my question perhaps for you, James, at this point is whether you might look at a lobectomy and maybe some general arguments for and against doing that in this young person.
Yes, I would be certainly considering lobectomy. I guess even on the first episode of major, potentially sentinel to life-threatening hemoptysis, I think it's articulated it would probably be involving a multidisciplinary team at that point with cardiothoracic surgeons, if available, not necessarily because you're going to whip the lobe out there and then, but, early planning from a surgical perspective, is going to be important in this setting, particularly if they do have catastrophic bleeds. So would you do a lobectomy? How many bleeds has he had at this point?
Well, let's go, Vicky, can we go back to the 5? Yeah, so 5 really bad sort of discrete events, and then little bits all the time mixed in with his sputum. So, yeah. But I guess the pattern there as well is that it's maybe accelerating, if anything, which I think was a cause for concern. Yeah.
Look, I think you've tried an IR approach. I mean, I think you'd be sitting down with the surgeons and the interventional radiologists and trying to weigh that up carefully. There's no kind of good answer here. I mean, you risk stroke would be my most feared thing if you keep putting particles down the bronchial arteries. By the sounds of things at the moment, that hasn't been successful so far. So I guess certainly it would require, as I say, multidisciplinary discussion. But I would be pushing, I think, towards a lobectomy at this point. What's against it? Obviously, it's a big operation. It's a lot to lose a lobe, I think, in a young man at this point. I guess it's certainly strongly tempting to think that the bleeding is coming from the dominant right upper lobe cavity. You suspect, I guess, just based on the CT, that's probably where it's coming from. It sounds from the bronchial angiography as though that's probably the case, but he's got, as you said, we've only seen the single cuts, but he's got pretty widespread disease. He's got a little cavity on the left, and you'd be a bit nervous that you take out a lobe and, there's other areas that are bleeding. So that would be difficult. I mean, this doesn't, but it sounds like, a florid inflammatory kind of vasculopathic type bleeding rather than the pulmonary arterial Rasmussen's aneurysm. With the CTs, do we know if they were like CT bronchial angiograms or pulmonary angiograms?
Yeah.
Or
He had both, but but yeah, certainly multiple CT bronchial angiograms.
Yeah. I mean, so that's also another challenge, I think, in this situation where, I mean, Rasmussen's aneurysms off the pulmonary supply, would typically need pulmonary angiography rather than bronchial angiography, so something to consider. But I suppose that's a very long-winded, waffly way of saying
yes.
Yes, I think now is the time you've waited, hoped, for TB treatment, for interventional radiology long enough, and the next bleed might be his last. So I think I'd be looking towards something definitive at this point.
Felt the same way. I did worry a lot about whether we were barking up the wrong tree and just focusing so much on this dominant cavity, but whether there was really a different culprit and we were going to end up resecting the wrong bit. But in any case, we had a lot of multidisciplinary discussions, exactly as you described, with radiology and cardiothoracics, and there was some concern from cardiothoracics that he may not tolerate the single lung ventilation, that you'd need to facilitate that lobectomy. So initially, the multidisciplinary decision would be to hold off, and that kind of coincided with what we hoped was some settling clinically. After that sort of 2.5 weeks, he then seems to go almost another full 2 weeks without any episodes, and we're kind of all hoping at this point that he's just improving with medical therapy. But unfortunately, at the start of the 5th week, he has a further episode. If you go to the next slide, sorry, Vicky. And so at that point, we do proceed with the right upper lobectomy, and he actually tolerates that well. He's in ICU for maybe 2 days and then back out on the ward really quickly. Next slide, please, Vicky. Unfortunately, 1 week post right upper lobectomy, he has a further large volume hemoptysis and code blue, and we're so sad. He's scared and really socially isolated and still under precautions and whatnot. And quite frankly, patients starting to lose a bit of faith in us, which is understandable at this point. So his imaging's repeated, and I'll show you a new axial. So the admission CT is on the left for comparison, and then on the right is the week 6 image. And you can see some progression of consolidation that's pretty impressive in that apical left lower lobe. And there's a Rasmussen aneurysm in that location as well, which isn't perhaps well represented here, but I promise you it is there. So I guess if we go to the next slide, Vicky, in summary, where are we? We've got this young patient, and he continues to have these life-threatening bleeding events despite embolization, despite surgery. He's had a month of medical therapy. We've shown he has adequate drug levels, and by this time we have confirmation that he has full susceptibility to first-line antituberculous drugs. So do you think that there is a role for steroids at this point, James?
Yes.
Yes. Would you care to expand a little bit on that?
If you go back to that, Vicky, can you go back to that the TCTs before?
Yeah.
This one?
Sorry. Yeah. Pardon me, I'm sorry, I'll move closer. The short answer, I would definitely think strongly / give steroids now. As much under the old adage that you shouldn't die without a trial of steroids as anything. I think he said he's had 3 to 4 weeks of what we believe is good treatment. I was going to say, is there any concerns with absorption? But I think you said the drug levels were adequate. There's no evidence of intra-abdominal tuberculosis.
No.
So we assume he's getting effective therapy at this point. He's had a good run on effective therapy. I mean, he'd lost 20 kilos, I think, prior, so he's functionally going to be immunosuppressed on arrival. He's been in hospital for 4 or 5 weeks now, so he's probably seen the dietitians. There's probably nutritional support. It wouldn't be surprising to think that there might be an element of immune reconstitution. So I think, for example, what you're seeing in the left lower lobe there, I talked about the paradoxical upgrade reactions previously. I would think this is far more likely to be, for example, in the left lower lobe, and a kind of paradoxical upgrade inflammatory response with that pulmonary inflammation driving neovascularization and ongoing hemoptysis, rather than treatment failure. I think this just seems to be very unlikely given everything he did to ensure that he was receiving effective treatment. So, yes, I would give steroids here to see if that had any effect.
Yeah, and we did. I think we didn't really know what to pick given, he's on rifampicin, and so then you expect that the prednisolone or the steroid exposure is going to be so much less. I think we ended up just going with 50 milligrams or something in this very evidence-free zone. And the other thing we did, you probably go to the next slide, Vicky, is a bronchoscopy. And until this point, we'd sort of been avoiding bronchoscopy with the feeling that it'd be quite unlikely to provide any therapeutic sort of benefit or diagnostic advantage relative to the imaging, and for fear of provoking a really intense cough, which is normal with bronch, and then further massive bleeding during the procedure. But we did do one at this stage, and I guess the rationale was to try and perhaps further verify that the new left lower lobe consolidation was indeed kind of the culprit site, given this is still someone with multifocal abnormalities on CT. But there was this sort of very clear predominant clot burden in that apical left lower lobe and in the lingula, and it did sort of seem to correlate with the radiology. So perhaps helpful in this context. Go to the next slide if we can, Vicky. He underwent a second embolization procedure targeting that Rasmussen aneurysm in the left lower lobe. So it was as James mentioned, a pulmonary arterial target, and that was done in theatres with a cardiothoracic surgeon on standby in case of catastrophic bleeding, which was the risk apparently, with sort of instrumenting close to a Rasmussen aneurysm, thin wall, and it could just all blow. And to the immense relief of everyone, that is a success, and he stops bleeding. He's observed on the ward for a further 2 weeks, and he seems okay, and he's asking to go home, and we feel it's probably not totally an unreasonable request given what he's been through. But at week 7, he's still smear positive, and we're at week 8 at this point. The cultures are proceeding from that week 7 sample. So I guess my final question here, James, is do you think the patient is still infectious to others? And should he wish to be discharged to shared accommodation, do you think that's okay?
I think he's very unlikely to be infectious to others. Alice, I'll admit you were showing me that paper from Clinical Infectious Diseases from last year, sort of with the American TB consortium discussing that. I mean, we know, I guess, that your transmissibility goes down very quickly with effective multimodal TB treatment, to the point that those recommendations, for example, now are saying that really people have for the most part, for most people, relatively negligible transmissibility, even within 5 days as a pragmatic thing. So you're at 7 weeks now, so you're a long way past that. I'd still be a little bit nervous if he was a nurse going to work in haematology ward with lots of bioablative chemotherapy, I think I'd still feel a bit apprehensive, if there were highly vulnerable hosts. But I think after 7 weeks of effective TB treatment, smear positivity notwithstanding, it would be reasonable to discharge into that environment with very low transmission risk. Noting, I guess, that negative pressure isolation in the hospital is not a benign intervention for the person themselves either.
Absolutely. That's sort of what we reasoned through, and we let him go, and he culture converted and smear converted, and he went on to do quite well and completed 9 months of therapy, I think. I think that brings us to the end of all of our cases. There's not much activity in the chat box, so I just wondered if anyone had any questions or anything related to any of the cases.
Alice, can I ask a question about, and I'm sure the answer to this will be very obvious to all respiratory physicians online, but when someone's having issues with hemoptysis, does doing a bronchoscopy have any therapeutic, is there anything you can do from a therapeutic perspective during a bronchoscopy, or is it just like a diagnostic thing?
So I think that the therapeutic advantage is probably overestimated a lot. If there's a region where there's minor bleeding, yes, but in the event of catastrophic bleeding, really your only option is an endobronchial balloon blocker, which a skilled bronchoscopist can kind of maneuver into the culprit large airway, generally either the right or left main bronchus, and occlude. The view there is to buy you time, allow for hemostasis and preserve oxygenation and ventilation. Obviously, that's something that's done kind of as an emergency intervention, almost something that might happen at one of these code blues. Code blues had this patient not settled each time he was having one of these massive hemoptysis events. But in terms of a patient who's having hemoptysis, and you're looking at whether you can go in there and do something about it, sometimes yes, in the context of some tumour, maybe some cryotopically or something of that nature, but in general, we try not to.
Yeah, I mean, I think I'll be forever terrified of the transbronchial biopsies that I have to get made to do. Having done the one or two where you do a biopsy and then all you see is red, and then you don't know where you are. So it can be a pretty terrifying thing from the bronchoscope, and difficult to manage once if you haven't, as Alice said, managed to isolate the bronchus where you're bleeding from, etc.
It is interesting to read some papers from clinicians who manage TB-related bleeding in high TB burden countries where perhaps they don't have the ready access to cross-sectional imaging. And some of those algorithms kind of decide, talk about doing a bronchoscopy first because it's so much more accessible. And you can look at where you think the bleeding is coming from, saying, is it all from the right upper lobe? Is it all in the right middle lobe? And then you might even decide to pursue surgery based on the bronchoscopic findings, because you may just not be able to access a CT. That's just sort of another interesting perspective, I guess. We're really privileged generally in terms of what we can access for such patients.
Thank you. I've realised that some of the questions are in the Q&A box, not the chat. So I'm just bringing those up now. Sorry, everyone. Andrew Burke's made a comment. Thank you. That they had a donor-derived TB in the lung transplant patient, and they used rifabutin instead of rifampicin, and did TDM, and the tacro dose was changed, but I think was pretty stable after that and easy to manage. So thank you, Andrew. And then, sorry, just going through these. Smo Barriers asked, would you recommend offering TB preventative treatment to all recipients whose deceased donor had an epi risk of TB? Matt, do you want to answer that?
I think that's probably a pretty controversial area. In lung transplant, for lung transplant recipients, and yes, probably that would be worthwhile. But in other organs, I think that's very clear. There isn't good data that helps us work out what the risk of donor-derived TB is from latent TB for non-lung organs. And it seems like the risk is probably low, but no one has really done those studies that sort of show how many donors had a latent TB risk and how many then had recipients that went on and got TB. And a lot of that data is missing from the people who are able to do some of those big picture reports. So I think there's a big unknown about that. I think as an ID physician, I often don't hear about it. So there may be many donors that have a latent TB risk that I never hear about, and they're okay, I suppose. I don't know. What do you think?
I would have a very low threshold for giving it, to be honest. And I guess with the idea that it can always be stopped if side effects occur and it's not tolerated, but definitely very low threshold to offering it and starting it, I think, if there was any epi risk. But there's another question for you, Matt, in terms of accessibility to rifapentine.
It's probably better answered by Alice and James, I reckon, because they have done the work to make it accessible. So you can describe what you've done, perhaps.
Yeah, we have advocated to have rifapentine on the formulary and have had that here for about 2 years now. So the answer is yes, we can access it, and that's all been going pretty well.
Cool. Chris Coulter has asked a question about is there a role for the WHO approved 1HP regimen for the donor? So presumably this was posted for the father who was going to donate his kidney to his son. I guess the benefit of 1HP would be it would eliminate the any potential delay in the surgery taking place. I don't actually know whether that's been studied in the sort of solid organ donor transplant setting. I guess I would be a little bit nervous about using it compared to sort of standard regimens, mainly given my lack of familiarity with it. But what do you think, Matt?
Yeah, I have the same thoughts. I have not used that regime. I think if you're going to do it, you want to know that you've done it properly, like treated latent TB properly, and so I'd probably try and give a more standard regime that I'm familiar with, that I felt more confident in. Yeah.
And then there was the question about the transmission risk if not treated for latent TB. This is so hard to define. I'm not sure. I think you spoke about that as well, Matt, but I don't think there's a way of sort of quantifying it.
Yeah, I think it's very hard to know. It's very hard to know if someone with an epi risk truly has latent TB, and then it's very hard to, like, there's no one's done a big study. It needs huge numbers. No one's done a big study that has good information about the donor's risk of latent TB and then has good recipient follow-up with data about whether they got latent TB treatment or not. So there's not published information about it to really know what the risk is in a low TB prevalence country.
Thank you. I think we've answered all the questions in the Q&A box. We've been talking for over an hour there, so I think we'll round things up. So Alice and I would just like to thank James and Matt. Thank you so much for participating in this. Thank you for Nishita for setting it all up for us. Please feel free if anyone online has any questions or feedback. Those are Alice and I's email address. Very happy to be contacted. But for now, I think we'll let everyone go and enjoy the rest of their evenings. Thank you.